Hello and welcome. You are one of 961 registrants to this ESGE video live endoscopy session, where the focus for the next hour is on tips and tricks for biliary cannulation. I'm absolutely delighted to be joined by my friends and colleagues, Marianna Arvanitakis from Brussels, Torsten Beyna from Düsseldorf, and my colleague at University College in London, Gavin Johnson. So we're going to be talking about selective biliary cannulation. Now, this is actually the most basic, the most fundamental, but also the most difficult and essential intervention in ERCP. So today we're going to be talking about some clever stuff at the end related to EUS access, but we're going to be focusing on the most fundamental thing we do in ERCP. If you can't get in the bile duct, you can't do anything. And actually, I think you can define the good ERCPist almost solely on the basis to which they can predictably achieve safe biliary cannulation. And we're going to be talking about some of the tricks and tips, but I think it's important to say at the outset, I love this quote from Gary Player, famous golfer, in which he says, "The more I practice, the luckier I get." And I think it is important to remember, nice study from the Netherlands a few years ago, showing that the more you do of ERCP, the better you get. And although I hope we will be teaching some of our expertise and tricks, the reality is that the more opportunity we have to do ERCP, taking on board the advice from today, the better and more successful we're likely to be. So without any further discussion, I'm going to hand over to my fabulous colleague, Marianna Arvanitakis from Brussels, to approach the initial steps of the patient with difficult biliary cannulation. Marianna, thanks ever so much.
Thank you very much, George, for inviting me to this very important webinar. So we start with the basics, with the beginning, and the beginning is Anatomy 101. So it's very important to know exactly where you're trying to get in, if it's in the pancreatic duct or the biliary duct. And also, it's very important to know a bit the anatomy of the papilla, of the papillary structure. We know that the biliary duct will go from 11 o'clock until a bit towards the left and upwards, whereas the pancreatic duct will go towards the right from 1 o'clock. So it's very important to see the direction that you're going to take using the device. And we see that you have this little common space there in the middle. And this is where we get sometimes involuntarily in the pancreatic duct when we want to go into the biliary duct. And as we talked about these directions, we see that when you're down with the duodenoscope, you can use your duodenoscope to get the good direction by pushing a bit further down, by turning your little wheel to the right, and to have already a good direction where your papillary orifice is a bit in the middle, but a bit above in the screen. So when you're going to use your device, you'll be coming from below the papilla. And of course, sometimes this is what we get, which is what we dream of every time we start in ERCP, a nice bulging papilla, not too bulgy, not too small, like the perfect size. We use here a sphincterotomy. We will have what we call an insinuation, that we will get into something. We feel that we're in something. This is this little common channel. And we will use the guide wire very slightly to go inside, maybe give it a little bit of a bend to be in the good direction. But when we have this feeling that we're in something, then if we are in the good direction, we have some chance to get into the biliary duct, as we were here with the guide wire. We will inject and to confirm, and then we will do a sphincterotomy by using our right hand on the scope to give the direction, good solid direction, again towards 11 o'clock in the biliary direction, and we will also get the landmarks we need, really establish the landmarks to have a complete sphincterotomy, depending, of course, on what we need to do. But if we want to take out some stones, of course, we need a complete sphincterotomy. So this is really the perfect cannulation, because we have the perfect conditions, but of course, it's not always the case. And here, sometimes our guide wire will go into the main pancreatic duct, as we see here in this X-ray picture. And then in this case, we will maybe consider doing a double guide wire technique. So we will take out our sphincterotome, leave the guide wire there. And then we see that there's some bile coming out. We can imagine there's just on top of the guide wire that's already in the pancreas. The guide wire will help us straighten a bit the anatomy. I think George will talk about the siphon, a word we don't like to hear, but this is an anatomy is not straight. It will straighten a bit. We'll give it another bit of a bend, and we'll try trial and error with the guide wire, a second guide wire, to get into the bile duct this time. The fact that the guide wire is occluding in the pancreatic duct also helps us to have more chances of getting into the bile duct this time. What do the guidelines say? We have these guidelines for 2016, and they haven't changed a lot. We will start with guide wire, but as also we will show later, sometimes it's important to give a little bit of contrast, a very small pulse of contrast, to see the distal parts of the trajectory of the common bile duct, and you will see that, as I said, it is not straight. Most of the time, it's not straight. Of course, both guide wire manipulation and contrast suggestion have to be very gently. And if you work by yourself or with your working assistant, we have to really know how to manipulate contrast and guide wire. And the double guide wire technique is quite up in the algorithm when we have a difficult guide wire cannulation, especially if we have an unintentional pancreatic guide wire insertion in the pancreatic duct. So in this case, we can go for the pancreatic guide wire assisted CBD cannulation or double guide wire technique. But in this case, we will always try to put a stent in the pancreatic duct at the end of the procedure. So so what happens when you have a difficult cannulation? Well, first of all, we will relax. We will take a deep breath and try to change a bit, either the instrument, either take maybe a smaller sphincterotome or an ERCP catheter, change position. Sometimes that can help as well. We work on the supine in Brussels, but sometimes we put on the left lateral, that can help. And then we'll consider the advanced cannulation techniques, the pancreatic guide wire assisted technique, as I just showed you, Precut techniques, where expertise is required, of course, and will also be shown later. Consider the general clinical situation of the patient, because maybe you can reschedule. If a patient doesn't have cholangitis and has just 4 bilirubin levels, maybe we can consider putting him 48 hours or even refer him to one of your good friends and colleagues in another hospital. So this is where we are in the beginning of the algorithm for our advanced techniques. And this is also considered in the recommendations, double guide wire technique that can be recommended, but always put the stent afterwards. And there was a recent randomized controlled trial that showed, by comparing if you do repeated single guide wire technique versus double guide wire technique, well, if you try the double guide wire technique, you have more chances of increasing the success rate of biliary duct cannulation. So for me, it's my first, let's say, advanced method of cannulation. And I think it's for you, George.
Yeah, fantastic introduction, Marianna. And I would just say to the 372 who are already online with us, there is a Q&A function. Please post your questions and we will either discuss them in these live sessions or one of us will do our very best to reply online. So Marianna, you've showed us what the guidelines show, and I just want to ask Torsten, what do you and maybe Torsten and Gavin can come online. Torsten, what do you do in your practice, in particular, the double wire technique or other approaches, if you inadvertently get into the pancreatic duct, what is your next approach?
Thank you, George, for this question.
Yeah.
So when we look into the literature, it seems to be clear that when we enter the pancreatic duct, at least for the second time, unintendedly, the literature says we should go for transpancreatic sphincterotomy as the option with the highest probability of successful cannulation and so on. But in my practice, I'm on Marianna's side. So when I enter the pancreatic duct with a wire, my first step is that for the first time, I pull it out and try to cannulate the bile duct again. But if I pass the second time, I go for double guide wire technique. This is my preferred approach because we have to put in a pancreatic stent anyway after the second time to protect the pancreas. And we have very high success rates if we go for double guide wire. And in terms of transpancreatic sphincterotomy, I always have the impression, at least in benign diseases, that we more or less destroy a little bit the anatomy of the papilla here, because we cut through the septum, we cut through into the biliary direction. So sometimes this is an option, but yeah. So my feeling is that double guide wire is not so bad as it is in literature. And yeah, George, what do you do?
Do you ever have situations in which you perhaps have a rather unstable duodenal position, and you are concerned that you may lose the pancreatic wire in trying to then cannulate the bile duct? Well, that's not a problem in your hands.
Usually not, but this can happen. So the option could also be that you put in a pancreatic stent beforehand, first to protect the pancreas, or as a second option to stabilize the papilla with a pancreatic stent. So this could be an option. And if I do transpancreatic sphincterotomy of the biliary sphincter, then I do only a very small cut. It's more like to increase the opening. I do not do a full sphincterotomy.
Yeah, we sometimes, rightly or wrongly, call that a mucosotomy.
Yeah.
It's not really cutting through the sphincter. Lots of questions coming through. What we're going to do is show the next case, and then we'll address these questions in the next Q&A. So the next case has got some audio attached to it, I hope.
My sphincterotomy is just getting caught on the edge of the diverticulum. So it doesn't look difficult, this, to be frank. Problem is that because there is a natural bend on the sphincterotome catches that outer lip of the diverticulum and then takes you away from the papilla. It'd be an interesting discussion as to whether people would just go straight for a pre-cut sphincterotomy here. There are other techniques that we sometimes use with duodenal diverticulum. Sometimes we try and clip above the papilla just to move folds out of the way. There we go. That's strip the wire, please. Okay. So we're in there. So maybe we're going to be okay here. It's really in the direction of the pancreatic duct, but that doesn't bother me here. Screen, please. Right. Now, I here am going to put in a pancreatic stent, and I'll show you why I want to do. Just inject a little bit of contrast there, please. Screen. Stop. I've had difficulty getting into the bile duct, but I am in the. I want to bring the ampulla out of that diverticulum. So what I'm actually going to do is I'm going to do a very small little mucosotomy here. This isn't a transpancreatic sphincterotomy. That's something we can talk about. So I need a little bit of bend, please. Okay, just yeah, that's fine. That's fine. I just need a little bit of. Okay, that'll do me there. 5 centimeter 5 French, unflanged. Now, yeah. My wire is clearly intraductal, but there's a little bit of contrast there that I don't particularly like the look of, but can't do anything about it now. Now I could do double wire technique here, but I don't want to lose this position, and I definitely want to have a pancreatic stent in. And I think I may be able to demonstrate that using a pancreatic stent here can be really helpful. So you can see that the papilla has now disappeared again. And what I hope to show is that by putting in a pancreatic stent, I can bring the papilla out. You see it's completely disappearing in there now. The problem is that I don't have good runoff, and I'm not terribly happy about the more proximal end of the wire, although it is ductal. Okay, so what I'm hoping is if this goes in here, I want to deploy the pigtail downwards. Perfect. Now, if I now release the wire. Okay. Now, the plan behind that is that hopefully, as long as the stent doesn't get carried out, I've opened that up a little bit. Okay, so there we go. So we're up the bile duct now. That bit of off with the bend. So I hope just in this first bit of the procedure, you know, we're talking about cannulation techniques, and I think that using the pancreatic stent in this situation just to stabilize the ampulla and actually to use the pancreatic stent as a splint here, which then has allowed biliary cannulation to be much more straightforward. And then gentle clockwise torque and push in, keep screening. It's beautiful. Oh, look at that. Amazing.
Gavin, can I ask you? You saw that ampulla when we started, and yeah, clearly we got a good result there. Is that what you would have done? Would you have taken a different approach to this ampulla? It was a prominent ampulla, but heading straight into a diverticulum in a rather odd position. Would you have taken this approach, or what else would you have done differently, if anything?
Yeah, I've just answered a question in the chat. Does your approach, your angles change depending on the morphology of the ampulla? In a way, it kind of doesn't. The principles are the same. You need to avoid a perpendicular puncture, which is more pancreas. You need to get below it, and you need to aim up towards the direction of the bile duct, which the ampulla points in. Often the diverticulum can help you, show you exactly where the angle of the bile duct is, because it forms the septum of the diverticulum very often, particularly if the diverticulum is between two if the ampulla is between two diverticuli, the ampulla aims in a straight line. So lining up your tone towards bile duct is often more straightforward if there's complex diverticuli. But the fundamental principles are the same. I have to say, if I get pancreatic duct cannulation early, I'm usually quite happy with that. So I would keep the wire in at the first entry into pancreas. That often keeps the ampulla out of the diverticulum. And then with a double guide wire, or if it's your preference to stent the pancreas first, then that's fine. I tend to go double guide wire and then a small septotomy. In malignant disease, I am an advocate of the transpancreatic sphincterotomy if I've got a wire in pancreas. I've hesitations in younger patients, which Torsten mentioned. I agree with that. But certainly keep the pancreatic duct with a wire into your benefit. It will make the cannulation of the bile duct with diverticulum much more straightforward.
Yeah, thank you. And Torsten, there's always been a bit of paranoia about duodenal diverticulum, haven't there? You know, either in terms of sphincterotomy, you know, and certainly in terms of access. Your tricks, both in terms of getting biliary access or even finding the papilla in a duodenal diverticulum, and then any particular advice about sphincter therapy, shall we say, in once you've got access, although the focus today is in cannulation.
Yeah, this is still sometimes challenging to have a diverticular at least once, or sometimes you have a couple of them. What my first tip is in this situation, if you get referral of a papilla that could not be cannulated within the diverticular, when you try it first, look outside of the diverticulum for the papilla. Very often we find it somewhere outside. So this is the first tip, I think. And then it makes sense if you are in front of the diverticulum, you try it and you cannot see the papilla, try to reposition your scope. If you can also try to enter the diverticulum with the tip of the duodenoscope. And if you cannot see it, you can also try the long endoscope position. Sometimes you have a better angle, you can see somewhere you couldn't see that beforehand. And once you can localize the papilla and you cannot cannulate, so of course you can try, depending on the position and of the position or the direction of the bile duct, that can vary in the diverticular from normal anatomy. Of course, it can also go down or go somewhere straight in something. Then you can try to use sphincterotomy or a straight cannula can sometimes be helpful. And then as a final option, you can, or in the days of EUS, that's not the final option, but we have as a good option, we can use some traction, maybe that can be helpful. I think you will be talking about that a little bit later. But also what I do in a very difficult position when I cannot find the angle, I cannot cannulate. Sometimes I use a very thin forceps, a spybite forceps, through the same channel. I use a spybite and then a thin cannula that goes alongside the spybite, and then I straighten just the papilla and can cannulate with the cannula. So I was not prepared for this. Next time I will bring a video, but this can be helpful.
No, that's, well, it's yeah, really challenging. Do you ever use clips? Have you ever, tried to clip the? It can be a nice idea in practice, but in theory, but in practice can be a very frustrating undertaking. But is it something you've had success with?
So I usually don't like clips here. So more or less with the spybite you can have the same traction. The difference is that you can remove the forceps and the clip is there. So clip line traction could also be helpful here. So I don't like the clips, but that doesn't mean that it's not working. Huh? If you have experience.
No. The part of this webinar is finding out what the experts don't do, not just what they do.
So
that's really
I
helpful.
don't use clips.
Let's go on to, I think, another. So over to you, Torsten, to tell us about Precut sphincterotomy.
Yeah, George, thank you. And also to all participants that already asked some questions about Precut sphincterotomy. I think this can be very helpful in our practice. So let's dive into the theory behind it. So here you can see we have already a pancreatic stent inside. And as you have learned before, in this situation, my first step would be to leave the stent here and try to cannulate into the biliary direction. But if I do not succeed, then Precut sphincterotomy using a needle knife is a very good and very successful option. Here, the first thing that you can see is that putting a pancreatic stent inside makes it easier. It stabilizes the papilla, it stabilizes your cut, and you know exactly where to start from. So here we would start from the papillary orifice here and then would cut into the direction of the bile duct. So you can observe here the bulging of the bile duct, and you would cut into this direction. So the needle knife is not fully out of the catheter. It's just 1 or 2 millimeters, because we want to cut very precisely the roof of the papilla layer by layer. So we don't want to cut too deep in the first cut. We want to avoid bleeding, and we want to have full control of our cut, like in ESD. So here the next step is that we cut into this direction. Importantly, when we do sphincterotomy, we we don't use the elevator. We use the needle to hook in here, and then we use a little bit of elevator to apply a little bit of pressure to increase the pressure here onto the tissue that provides a very safe cut. We use endocut as an alternate cutting current here with a low setting of coagulation, and then we cut into the direction of a bile duct. So, and what we want to do is we want to expose below the mucosa here of course, the biliary orifice, but also the anterior wall of the CBD. Let's see here. So this was after the first cut. We can already nicely observe here the anatomy. So we can here see a little opening, and we can see here muscle fibers that usually derive from the anterior wall of the CBD. So let's see here. So here one more cut, just very gently cut here into into the biliary direction. Then we can see here a small opening, and after that we can do a deep cannulation. Let's see again in a video the same patient here again. So we go in with a needle, we apply pressure, then we don't touch the needle anymore. We use our right hand to hold the endoscope like a surgeon does with his scalpel. And so we cut into this direction. So we don't cut too deep. Layer by layer, we open here the papillary roof, and then we start again from below. So luckily we don't have any bleeding here. We can already observe here the anterior wall of the CBD, and then we go back and do another cut here from the so the red spot is maybe the orifice. One more cut. Sometimes we can already see bile coming from the CBD here at that stage, and then we just remove the needle from the catheter, and we can cannulate here into the biliary direction and complete the procedure. So there was already a question about the timing of the Precut. So we had some data already more than 10 years ago. This meta-analysis comparing 6 randomized controlled trials about early or Precut or persistent cannulation. And as you can see here, deep cannulation doesn't differ here between both groups. Complication rate is on the same level, and in particular the post-ERCP pancreatitis rate is not here, it's not significant, but it's 5% in the persistent cannulation group and only 2.5% in the early Precut group. And let's see if I can switch here to the next slide. Okay, here it worked. So 2 years ago, there was another, the so-called meta-analysis comparing all the different techniques of cannulation, including also transpancreatic sphincterotomy, early or late Precut, persistent cannulation. 17 randomized controlled trials, more than 2,000 patients. And here the only technique that resulted in a significant increase of cannulation rate was a transpancreatic Precut, transpancreatic biliary sphincterotomy compared to all other techniques. But the second best option was the Needleknife Precut here. And as described before, I'm not so in favor of the transpancreatic Precut. Both transpancreatic and Needleknife had lower PEP rates compared to double wire technique. However, I still think double wire is still valid to use nowadays. So let's have a further look. Let's see. Okay. This is data from the Swedish registry. Almost 50,000 ERCP cases have been included, recently published, comparing transpancreatic sphincterotomy versus Precut sphincterotomy. And here you could see, so of course the control group has higher rates of deep cannulation because these were the easy cases. But here you can see that deep cannulation was more frequent in the transpancreatic group. However, complication rate was higher compared to the Precut sphincterotomy group. So what should we do now? I think we have tailored approaches depending on patients' individual anatomy and if you get into the pancreatic duct or not. For example, here we have been talking about diverticula, so I will start the second video as well. Here, so here, what on the left-hand side you see diverticulum, duodenal diverticulum. The papilla is inside. Even with the sphincterotomy, it was not possible to enter, and at this point, it was necessary to do a needle knife precut here. So always be aware that anatomy is different, so you don't have a thick muscle layer. Be careful where to cut. But if you see this bulging of the CBD over the papilla, you can also go for needle knife precut sometimes, and this is also in the literature is the so-called fistulotomy. If you come from above, seems to be even safer. You can do that as well, but I believe in needle knife starting from the orifice, and then you can use here the sphincterotome on the left-hand side, and then you have a pancreatic wire in place. You can do here a transpancreatic extension of the sphincterotomy, and then after that, here it was possible to put in a biliary guide wires. So after that, and as you can see now, it looks much nicer after precut and putting a wire into the pancreas that straightens, as Gavin mentioned before, it straightens the papilla, brings it out of the diverticulum, makes life easy. And here on the right hand side, of course, if you have this large protruding papilla, then you can just go straight forward with the needle knife. So this was just my short presentation about precut. So maybe there will be some additional questions.
Yeah, there are always lots of questions about precut. Yeah, lovely demonstrations. And I have to say, I really like your demonstration, Torsten, of the two-step approach to de-roof the papilla initially, expose the biliary, the bile duct, and then do a second cut down onto the bile duct. So too often we see people burrowing through the ampulla in a rather uncontrolled way. Marianna, can I ask you? You've been involved in training for a long time. One of the areas that fellows will get the least training in is doing a precut, because of course the scenario is the trainee starts with native cannulation, they can't get in, the trainer takes over, they can't get in, and then there presumably is a real need clinically and in terms of patient care to get into the bile duct. And it is absolutely understandable that the boss then does the precut. And what that then results in is fellows completing their training, having done sometimes no precut sphincterotomies. Do you see that as an issue? Is it only a problem in the UK? How do we, what's the answers for that?
I don't know if I have any answers, but it's definitely a problem everywhere, not only in the UK. I think that, first of all, you have some very good opportunities now to do hands-on training on models. We have very nice mechanical models with a papilla that you can do sphincterotomy. You can do precut from chicken heart. So if we can get that opportunity for our trainees, I think it's already great to be able to feel how we use how we move the device by using the scope and what Torsten pointed out and all the steps. I think that you shouldn't when you start your ERCP training, we know that this is going to be lifelong training. So I think that if you haven't done any precuts in the first 2 years of your ERCP training, there still have a lot of possibilities to continue mentorship and ongoing training, and we'll have the possibility to do it in that time. So maybe if it's not going to be something to learn in the first 50 or 100 ERCPs in my opinion, but something's going to be advanced learning for afterwards. But it's true that these advanced techniques will be acquired afterwards and not in the first 2 years maybe.
Yeah, no, absolutely. And I think the point you make, there's a mechanical model for ERCP from developed by Cook and the Costamagna and Eva Bukowski, and there's a nice chicken heart that actually can allow people really to practice nicely on pre-cut sphincterotomy. Gavin, one of the things that we like about interventional endoscopy is that we can choose the data that we incorporate into our practice and ignore the data we don't want to. Would you be prepared to say that we don't want people going away and thinking that transpancreatic sphincterotomy is high up the list of approaches for access?
That's the first time I've seen that Swedish data. It's interesting with a complication rate. I would caveat my remarks earlier that I would use it in a patient with a pre-procedure low pancreatitis risk. So that would be your old boy with a big cancer head of pancreas that you're just trying to get a stent into. Pretty low risk pancreatitis with a chronically obstructed duct or chronic pancreatitis, something like that. The 21-year-old with small stones in a small duct, I would not want to be utilizing a transpancreatic, but that's not particularly evidence-based, although maybe now it is with Torsten's data that he's just shown us. And I've got a quick question back to you, George, if I might, because I can answer it in the chat, but there are certain advocates for a primary needle knife. So you see a big bulging papilla, type 3, if you want to give it a name. And people advocate, forget trying to get into the os with your sphincterotome, get your needle knife out up front. I know that's something we don't particularly practice, but any comments from you or Torsten or Marianna on that?
There are, in fact, that video that I showed of the duodenal diverticulum papilla, that would be an ampulla that I would think about primary pre-cut, but I think it is the bulging ampulla classically where there is a stone impacted at the ampulla. Definitely, I would consider a primary fistulotomy in that case. There would be almost no other cases, and definitely the small or normal papilla, I couldn't consider a scenario in which one would use a primary needle knife. But the bulging papilla with a nice long length between the papillary orifice and the duodenal wall, then there may be situations in which I would consider that. And I would bounce the question back towards Torsten that I think clearly in the case you showed, but I think you also said in your discussion, Torsten, that you favor a sphincterotomy rather than a fistulotomy. Does that include the patients where you do not have a pancreatic stent in?
This is a good question because we know that the risk of pancreatitis is lower in fistulotomy. If you have this huge bulging CBD and a long distance, as you mentioned, between the orifice and the duodenal wall, I would also go for fistulotomy here. But usually, you like to use what you have been trained most, and as far as I can see and reach the orifice, the papillary orifice. This is just my feeling. I don't have data on that, but if you can see this bulging, then of course you can also go for fistulotomy. And so the risk of pancreatitis might be higher in the patients without stent, and then you can cut away from the pancreatic orifice. That might be an advantage here.
Yeah, and I always feel much more comfortable doing a pre-cut if I've got a pancreatic stent in.
Yeah.
You know, it allows you to also maintain your understanding of the anatomy.
Yeah.
You know, it makes it all much more straightforward. Let's move on to a case that we just had a week or so ago in our unit, but I think covers another topic.
Here we are, doing procedure with Heng, one of our excellent new fellows. It's a patient with bile duct stones on MRCP, and looking to clear. So this is what I like to see: slow, soft hands, no quick movements. Very nice. And then we always lead with the wire, and we lead under screening. Looks like a lovely line. I'm not sure you are really. I don't think it's a crime to put a little sniff of contrast just to see where you are, as long as you do it under active screening. Screen, please. And just inject there, stop there. So there we are, you're filling the, well, what are you filling there? Yeah, just inject a little bit more there, because you might be filling the lower end of the bile duct with a sigmoid bile duct. And there you are, it's exactly what you're doing, and there's the stone. Stop there. Now, take that picture. So that's really interesting. So you can see that if you, how are you going to get into the bile duct here? So what you want to do here, and it's an active maneuver, because you can see that it's a sigmoid lower duct. To do this, you're going to want to shorten your scope. So pull back your scope. Screen, please. Let's do this all in one. Let me just explain what you need to do, because there's different movements. You need to shorten your scope, you need to drop your bridge, and you need to take the bend off the sphincterotomy, because you need the wire to go flat and then come round. So let's do that. Stop screening. But so you need to shorten your scope and maybe thumb up and straighten your scope out. Screen, please. Very nice. Now you can try your wire now. Nope, stop. It's going to push you out. Okay, now you need to take the bend off the sphincterotomy and shorten your scope more. Stop there. Stop there. Now put a bit of contrast in now. Now you're filling the PD. Isn't that interesting? So, okay, stop there. You can just try and go with your wire. It might flick here. Screen. No. No. Okay. So this is a very good example where actually having a bit of contrast really helps you to define the anatomy. Do you mind if I just have a little wiggle here, Heng? Because this can be very, very tricky. Right. So let's just put a little bit of contrast in there. Screen, please, and inject there. Stop there. Now, what I'm going to try and do, screen please, is shorten the scope. There's we are. There we are. I'm really short now. I'm going to go with the wire. And there we go. Round the corner. What a very interesting example. Yeah, well, but so really useful there. Really useful to have the contrast to guide us. Okay, back to you, Heng. Yep. Can you? That's it. Superb. So we're going to do a little cut now. Out with the sphincterotomy, and take that. I think we're done.
Okay, so you know a very sort of specific example, and Marianna mentioned earlier the so-called siphon or sigmoid distal duct. And the techniques that we tried to show there are when you've engaged the papilla, you shorten the scope, you go tip down, you lower the bridge, all to allow the sphincterotomy to go more laterally initially, and then advance the wire under fluoroscopy usually. And then, of course, we only select our most successful cases in those sort of cases, but quite a nice, I think, quite a nice example.
George, can I just,
yeah, sure. No, Marianna, yeah.
No, I think it was beautiful, really beautiful what you showed, and important to understand the anatomy, because if we just try to go straight in, it's not going to work, because we're in the curve and we're just accentuating the curve. But this is what our older generation called, we did the horseshoe maneuver by doing a cannulation with a sphincterotomy, and it was exactly these movements. So once you have the first part of the bile duct, then you go a bit up, a little bit to the left, and you follow this anatomy, this sigmoid anatomy of the distal bile duct. And then when you pass that second part, then you go back on the right and then push back a bit your scope and you're in. But it was beautifully shown.
And I think that one of the sort of lesson in that case really was a little bit of contrast. And Torsten, for many years, using contrast as part of biliary cannulation became a crime. We were obsessed with wire-guided cannulation, and putting contrast was seen as absolute failure. What's your practice? In what scenarios do you use a bit of contrast, and do you think it is a crime?
Definitely not, not a crime. But as Marianna nicely explained, if we go for, if we don't expect some difficulties in cannulation, like a distal stricture or a neoplasia at the level of the papilla, then I usually try normal cannulation maneuvers, like Marianna nicely explained. So we cannulate, try to enter the papilla with the tip of the sphincterotome, and then we bend the sphincterotome. At that level, we can straighten a little bit our position, pull back, turn our small wheel to the left, and bend the sphincterotome. And while pulling back, we again straighten the sphincterotome, push the wire, and then we get a little bit deeper and we overcome this angulation. And then going back, using again the small wheel to the right, pushing a little bit forward, using the large wheel to hook a little bit with the sphincterotome, and usually then we slip in. And if this maneuver fails for the second time, I would put in a little bit of contrast, because then we have a little bit different anatomy of the distal CBD, and sometimes we do different maneuvers then, and we avoid more traumatic maneuvers with the sphincterotome, or even perforate the angulation with the wire.
Yeah. Gavin.
Yeah, quick one. I would encourage our trainees to make the most of the prior imaging, because it really does give you a little bit of heads up on cannulating. It's amazing how often fellows, they know their patient's had an MRCP and it's just a stone, but actually it's worth taking the time to look at that MRCP. It will tell you that the pancreatic duct might follow the bile duct for a hugely long parallel aspect. So you might think you're in bile duct, but you're not. So you need to have that little alert. Another example is if the stricture is incredibly downstream, your wire might be in the perfect spot, yet you're hitting the stricture, and a trainee might think, oh, I'm just not getting in here, I'm in the wrong plane. So make the most of your prior EUS or your prior MRCP, less so CT, of course, to really understand the distal anatomy of both ductal structures as they enter the ampulla would be a tip.
Yep, fantastic. Okay, so great discussion again. Let's now move on to Gavin. We're unapologetic to sort of end the session on the more advanced techniques, because these are needed in a proportion of patients, and we need to have an algorithm as to how to approach the patient when these conventional techniques have really proved either we've tried them and they failed, or we've not even tried them because the anatomy would preclude. So, Gavin, over to you. Thanks.
Thanks, George. Yeah, so this is one slide, but it's heavily animated, so I will keep you 4 or 5 minutes. So this is an image on the top right that I'm sure people are familiar with. So essentially, your access to the biliary tree via EUS is into the left liver, seldom right liver, but certainly left liver. So number 1 is going across the wall and leaving a stent, hepatogastrostomy. Number 3 is to use the left liver as a conduit to the papilla, either by using a rendezvous technique where you swap out to ERCP, or indeed in the context of a stricture stenting antegrade down through the liver and down on fluoroscopy. And if the duodenum is an option, you can stent straight into the bile duct. That's number 2. That's a choledocho duodenostomy, which have gained great traction in the advent of LAMS. And 4 is using the duodenum as a conduit to the bile duct for a rendezvous maneuver, which can be a little bit tricky and challenging in benign disease. So what I'll talk you through now is the sort of, I wouldn't say standard operating procedure for me, but this is the sort of algorithm that we're talking about. So the first thing to understand is if there is no prospect of doing an ERCP in the context of surgical alteration, what's the plan? Well, if that is a Whipple patient or a hepatogegenostomy Roux-en-Y, where the Roux loops are considerably shorter, then I think it's reasonable to have an attempt at enteroscopic assisted ERCP if you have the expertise. Single balloon may be sufficient because the Roux loops are shorter. Double balloon if you have the expertise. But if this is a Roux-en-Y gastric bypass, as depicted here, that's not something we bother with enteroscopy. And we've had great success in recent years with the EDGE procedure, where one puts a lens between the gastric pouch and the excluded stomach, and then place a large lens to conduct a natural transgastric ERCP in the normal fashion. Again, lots of tips and tricks behind that, but a subject for another day, but an excellent technique. If there is an extrahepatic stricture and the ERCP has not been possible or you have failed, then again, there are options. If you have access to the duodenum, this is where it's an excellent option for an EUS choledocho duodenostomy with LAMS, often really very straightforward, particularly in a very dilated extrahepatic bile duct. So if you've got an infiltrated papilla or a cancer head of pancreas, this is a fantastic option. But do beware that we know that if there is associated gastric outlet obstruction, then these patients don't do nearly as well until the stent fails, probably due to reflux of food into the stent. So you either need to manage the gastric outlet obstruction at the same time, preferably with a gastrojejunectomy, but certainly not a duodenal stent, or think of an alternative modality. That alternative modality might be either EUS antegrade stenting via the stomach, or even an EUS hepatogastrostomy, because your left and right ducts will be connected with an extrahepatic distal stricture, and you're going to drain well that way. Or, of course, PTD remains an option. I've not got a slide on talking down PTD, but certainly we have an ethos in our unit that if we can avoid a PTD and a prolonged hospital admission with old, frail patients, that's something we're really always going to aim to do. If we don't have access to the duodenum, this rules out a LAMS into the bile duct. Then you're back to either antegrade stenting, or what is often straightforward, but it is determined on there being sufficient left-sided intrahepatic ductal dilatation, is a hepatogastrostomy, or again, a PTD, an antegrade stenting. And if it's a hilar stricture, then there's a little bit more thinking to do. So if this patient is set for surgical resection, you need to have a very careful conversation with your surgeons. They may not want us meddling across the gastric wall for HGS, etc. They might want all that intact. And often this is a role where we might be doing primary PTD for a patient who's bridging to surgery. If all your intention is to palliate, then this is an excellent indication for an EUS hepatogastrostomy, so option 1. Again, it's well described that you can do a right-sided hepatoduodenoscopy. We've not done so many of those ourselves, but stenting within the bulb. But certainly the left side is straightforward, and I think the stents will improve, whereby we might make this a more straightforward procedure, just as hot LAMS have come on market and made this a much more democratic procedure to do. I suspect we're going to see changes in HGS to make them more straightforward as well. Now, in benign disease, that's more contentious because you don't want to be leaving metal stents in and so on. Do remember that if it's a reasonably small stone and the patient has a gallbladder, then it's an excellent indication for a laparoscopic cholecystectomy and bile duct exploration, if your surgeons have the expertise. So that's an option always worth considering if an ERCP has failed. If that is extrahepatic stones, then this is a great one for the EOS rendezvous, either via the stomach if the left-sided ducts are dilated, although in benign disease, very often the left ducts are not terribly big, so it precludes number 3. And option 4 with a short scope can be quite challenging. And what we've found, particularly in sick patients, is that it's perfectly acceptable to put a small lens in, so a choledocho duodenostomy, to temporize the patient who's cholangitic, an old patient with a big bile duct, and then bring them back a couple of weeks later to do an option 4 rendezvous via the lens. When the patient's controlled, you've got much greater wire access. You can go again with your wire to flick it down. And we've got a good case series on that where it's been really quite successful. If the trouble is in the liver, either hepatolithiasis or strictures, then I think this is an increasing role for PTD again, particularly in the advent of transhepatic cholangioscopy and lithotripsy. But again, if that disease is left-sided in the context of benign disease, again, we've had good experience of leaving fully covered metal stents as a hepatic gastrostomy, which can be removed in the future to gain access to the left side of the biliary tree or anastomoses and treat what has proved to be quite complex hepatolithiasis on the left in the context of benign disease. But essentially, know your patients, multidisciplinary discussions, and have these sort of tools up your street. Single slide left is a fairly recent meta-analysis based purely on RCTs, which is always encouraging when it comes to meta-analyses, looking at primary drainage of malignant biliary obstruction via EUS. So this would be a choledocho duodenostomy rather than attempting an ERCP. And I think this is something we're going to see an awful lot more of, in that the technical clinical success and adverse events were favorable towards EUS-guided access. So this is quite interesting data, I think. Although do be mindful that this should not be done if there's gastric outlet obstruction. So a whistle-stop tour. I'm sure we could spend a whole hour talking just about that slide, but hopefully sort of set the scene for future discussions. Thanks, George.
Brilliant. Yeah, as you say, Gavin, we could have a whole other webinar, and we probably will, on the EUS access approaches. I mean, I suppose getting back to the topic of the webinar this evening, Torsten, where do you wish to consider very early an EUS biliary approach, where previously you may have at least made attempts at ERCP? I suppose we've all had experience of the big, nasty ampullary cancer that, you start trying to cannulate through some friable mucosa and it all starts bleeding. In your unit, is that a patient that now you would say, look, actually, we're going to go for an EUS here? Or, what would be your patient selection? Because as Gav said, these are nuanced questions and they're very patient-centered.
Yeah, this is a very good question and quite easy to answer. So if we have patients, in particular, when we know that we have a palliative setting, like you mentioned, the huge tumor, pancreatic head tumor, ampullary tumors, we would at least have a look at the papilla once, but as it turns out to be difficult, we would immediately switch to choledocho duodenostomy using luminopoled metal stents here very early, and then it takes 5 minutes and the whole thing is done. And in case of duodenal obstruction, for example, because of an advanced cancer, we could easily go for, and we cannot reach the CBD, we can easily go for EUS-guided antegrade drainage. Is also a one-step procedure here, maybe as a double bypass using a gastroenterostomy. So nowadays we easily switch. This is different, I think, in benign diseases. So there we would definitely not go for EUS as a first approach, except altered anatomy, for example.
Okay, fantastic. Well, look, we've had I think a fantastic hour covering a large range of topics, all focused on biliary access. We're pretty much at the end now. I'd like to thank my co-panelists, Marianna, Torsten, and Gavin for their input. Actually, we have basically just turned up and told people what we think, but in the background, the support of the ESG governing board, I think it's a great development that we've been doing now for a couple of years of these video live webinars. And the webinar team, David Inca and Vasso from ESGE, thank you so much for their support. Now, if you're like us and you can never get enough of HPB endoscopy, or any form of endoscopy for that matter, then there are a few things. We've got our virtual London Live endoscopy meeting in a few weeks, free registration. You can join us from the comfort of your bedroom if you want. It'd be good to see you. Torsten is hosting with Horst Nauhaus the fantastic Dusseldorf International Symposium. And just to note, if you attend that meeting, there is the chance of free registration to the real big event for the ESGE coming up in Barcelona, which is the ESGE days. Get going quick. You've got a couple of weeks for early bird registration. Fantastic venue, fantastic meeting. And other things, if you still haven't had enough, the ESGE Academy has now been running for a couple of years. Amazing resource. You have to be an ESG member, so one more reason to join the ESGE. And from next week, there will be a new app making it even easier to access everything that the ESG offers, including the webinar this evening, if you really want to watch it all over again. Finally, we keep on with the webinar series, and actually a really, really important webinar next week. There is a tendency, maybe a little bit, as we've shown today, we've shown lovely cases that have gone well. There's lots of teaching to be had from the case that goes well, but there's possibly even more learning to be had from the case that does not go well. And we've tended over the years to hide away our complications, and that's bad on every level, because then nobody gets the learning. And so next week, a superb webinar on complications. My worst complication, upper GI, lower GI, and ERCP. I hope not all in the same patient at the same time, but that will be a fantastic webinar, and I hope you can join us for then. So thank you so much for everybody who's joined us. Thanks to ESGE and my co-panelists, and have a great evening. Thanks ever so much.
Thank you.
Thank you very much.
Bye-bye. Thank you.
Have a nice evening.